Assalamu alaikum, good morning, good afternoon, and good evening. I hope everybody is doing great. Today is our first day of uh, and free and special class, which we are going to have it every Sunday. And probably from the next Saturday, we also have classes from Saturday 6 to 11 and Sunday from 6 to 11. So today we are going to cover the most important topics that covers all family medicine. So preventive care, and then we are going to do the uh, chronic disease management. Okay, so let's start with preventive care for now. So the learning objective for the preventive care is identify the eligible patient. So who is eligible when we are covering the preventive care or dealing with the preventive care? Obviously, in terms of age, in terms of sex, in terms of pregnancy status, risk factor, family history, symptoms, life expectancy, province, program context, it will be different. And choose the correct test preferred Canadian screening pathways. This is also the objective that today we're going to cover. So basically the FIT and also the CRC, colorectal cancer, HPV, PAP, and by province, a mammography, LDCT, and also ultrasound for the abdominal aortic aneurysm. Avoid common traps. So these are the things that you pay attention while we are doing the lecture. I will definitely mention that these are the things that you should not do. For example, if you have somebody who is symptomatic, so do not bother or waste your time in screening. We usually do the screening when the patient is not acutely sick or the patient is not symptomatic, right? So we do the screening for somebody who is asymptomatic and we just want to catch some sort of dangerous condition in advance to deal with it and prevent it. But when somebody develops symptoms, so this is a common mistake. Usually we go after the screening. If somebody is symptomatic, forget about the screening. If you see any screening, just skip it. Go after the most initial or confirmatory based on the question diagnostic tools. All right. Avoid low value screening. Use shared decision making. Always involve the patient in his or her condition. So do not just decide on your own. Always involve the patient. Whatever decision you're making about his health, you need to involve the patient. How the MCQ one test the preventive care. So asymptomatic, they may give you a scenario which the patient has no symptoms, and they may ask you based on the scenario, what is the best next step. Obviously, for somebody that who is asymptomatic, we usually try to do the screening, not the diagnostic, because the patient has no symptom to diagnose, or the patient has no complaint to go after any diagnostic tool. Now, they may give you a scenario that the patient is symptomatic. For example, the patient has bleeding. The patient is elderly who has bleeding, upper GI, lower GI. Then, now it's not a good time to do the screening because the patient has already developed the symptoms. So, if you see on those options that there are some screening factors or some screening options, just skip them. Go after the diagnostic tools. Risk factor, earlier or different test. Frail, limited life expectancy. So if you have somebody who is frail, who has like let's say 6 months to live, so don't waste your time doing screening because we do the screening to find something in an earlier stage to prevent it from progressing. But somebody that who is dying in 2 months, it is waste of resources. It is waste of government money, and it's just unnecessary screening, right? So just avoid it. Preventive care is not order everything. It is a disciplined decision about net benefit, patient risk, and timing. So the MCQ1 traps, again, this is something that we need to keep ourselves away. When a case contains bleeding, let's say they gave you a scenario about somebody that who is 70 years old and the patient is actively bleeding from, um, let's say the patient actively has lower GI bleeding. The patient has mass, the patient has weight loss, severe pain, neurological deficit, and instability. The question no longer asks for the screening. Or if you go after screening, that is the wrong answer. Why? Because the patient has already developed symptoms. Remember, asymptomatic screening, symptomatic diagnostic. Okay? Preventive care visit framework, cancer screening. For cancer screening that you will be tested in MCQ1 that you cannot miss, please cover breast cancer, cervical cancer, colorectal cancer, lung cancer, prostate cancer, prostate discussion when appropriate. So these are the cancer that you need to know. What is the next step? When do we have to do the screening? Who is the candidate? At which time? And how many times? What are the frequency of redoing the same screening? Okay, so these are the things that you need to, as an IMG, if you're preparing for MCQ1 or NACOSKI, you will be asked. There will be a question from these cancers. If you're doing NACOSKI, it might be part of the past encounter question. But if you're doing MCQ1, it will definitely be in your exam. Immunization, influenza, COVID-19, they love to ask this since it is very recent and they love to ask it. TD, AP, TD, pneumococcal, shingle, HPV, and respiratory syncytial virus, we're eligible. So these are the vaccinations that you need to cover for MCQ1 if you're preparing for one. Mental health and safety, another screening that we need to do is in psychology or psychiatry. Depression with clinically indicated, suicide risk, intimate partner violence, substance use disorder. So these are the topics very commonly tested. If you haven't covered it, please go and cover it. If you have account with us, you definitely have all these notes in your account. Please go check your account, check these notes, and based on these notes, we have questions. For every single topics that you see here, we have cases. We have tutorial cases and we have quizzes. Please go cover them. If you're preparing for MCQ1, do not attempt the exam unless you cover all this, okay? Cardioembolic risk, the blood pressure, which today we are going to cover it, lipid, which we have already, these are all of them we have already covered it. But today we're just going to do a revision, okay? Lipid, diabetes, smoking, obesity, atherosclerosis, cardiovascular disease, risk, behavioral health, tobacco, alcohol, activity, nutrition, sleep, sexual health. Older adult prevention, falls, frailty, cognition, if concerned, medication, function goals of cover. So these are going to be in your licensing exam. If you haven't covered it, please cover it. And today we're going to talk about all of them. So now we're going to move on to cancer screening. Okay. For the cancer screening, again, we will focus on breast, on cervical, colorectal, lung, prostate. This one, I think you do have it in your notes. So let's start with the cancer screening. On one slide, the whole summary. So the cancer average risk exam answers. Okay. So if they are going to have, if they're testing you about breast exam, what they might want you to know. They want you to know that the mammography is one of those options and it has to be every 2 years. And the reason I made it red, very commonly tested. Very commonly tested. Please remember that. Common age is 50 to 47, but age 40 to 49 increasingly offered by the program with the shared decision making. Again, it means you can start it as early as 40, but you have to have the patient involved in that decision making. But commonly, age 50 to 40, 74. Now, for cervical, HPV-based program increasingly start at 25. Recent changes in the guideline, they prefer HPV-based or HPV tests. Okay? Ontario HPV every 5 years, age 25 to 69 if average risk. And pap test is the same thing as before. 21, you can do it every 3 years. This one starting at age of 25, and you can redo it every 5 years. Colorectal, FET, remember, FET every 2 years, starting at age of 50 to 74. So how they're going to test you on this one, they will give you a scenario about someone that, let's say someone that who is 70 years old or 65 years old, and the patient is here for a screening, right? So for the screening, you do the FIT. If it is normal, you do it after 2 years or in 2 years. But let's say if the FIT is positive, then the FIT positive is an indication for colonoscopy. So when do we do colonoscopy? We do colonoscopy if the patient has symptom. Then we do the colonoscopy. Okay. Lungs, the CT, age 55 to 74. For what kind of population? Somebody that who is smoking for 30 packs, who's smoking 30 packs per year, or someone that who is currently smoking, or he's a smoker, or someone that who has quit smoking, but it's less than 15 years. Let's say he quit smoking 10 years back. Still, we have to do it, and still, we have to do the low dose CT scan repeated every 3 years. So, a scenario. The scenario is you have someone that who is 55 years old, the patient is smoking 30 cigarettes per day for 40 years. What is the next best step for this patient? 55, right? So it's above 50. The patient is smoking for how long? For 40 years. So it's more than 30 years. Now, what do? I do a low dose CT scan for this patient. So low dose CT scan, I did, it's normal. So it doesn't mean that I don't do it. I will repeat it every 3 years for up to 3 times. Every year for up to 3 years. Okay. Prostate, do not order the PSA automatically. It's not very specific. It's not very specific. Discuss benefits and harms with the appropriate age risk. Breast cancer screening, average risk approach. So for the breast cancer, the average risk approach is age-based. What is the age? 40 to 49. Shared decision making and program dependent access. Age 50 to 54, mammography about every 2 years. Again, this is the time that it really depends on you and your patient based on the past medical history, based on the family history and current condition of the patient that you decide. But this is actually the best time to start it. Age more than 75, individual based on health values and life expectancy. So usually this is the perfect timing. That's why I made it red. Anything that you see red, it means this is commonly tested. This has been in the exam and it will most likely be again in the exam. So anything you see in a red, please take it very serious. High risk feature if your patient has BRCA mutation, prior chest radiation, multiple affected first degree relatives, early breast or ovarian cancer in the family. So these are high risk. Now, exam traps, again, Breast lump is diagnostic, not screening. Again, the patient has symptom. If the patient has symptom, forget about screening. Go after diagnostic tools. Ultrasound is not routinely average risk screening. And do not rely on breast self-exam as a formal screening. Always ask family history. Do not forget about this because it makes a lot of difference. Why? If the family history is positive, the patient is high risk. Cervical cancer screening. Scenario, you have someone age less than 25, asymptomatic, no routine cervical screen for average risk patient, right? For cervical. So if age is less than, when we are talking about this, we are talking about the HPV. Okay. Age 25 to 69, cervix is present. It means the patient has not done total hysterectomy and cervical resection. So screen according to the provincial program. HPV testing is increasingly the primary test in Canada. HPV vaccinated still requires a screening when eligible. Total hysterectomy, cervix removed, benign indication, usually no further cervical screening if no high risk history. Postcoital bleeding or visible lesion, again, this is symptomatic. If symptom, diagnostic evaluation, not routine screening. MCQ1 trap. Ontario introduced the HPV testing as a primary cervical screening test in 2025, with the average risk of screening every 5 years from age 25 to 69. High-risk patient, immunocompromised. If your patient is immunocompromised or if your patient is having prior high-grade lesion, DES exposure, abnormal result need a special pathway and closer follow-up, or your patient is receiving high dose of steroid or immunosuppressant, which I forgot to put. Colorectal cancer screening, average age is 50. We start with FIT and repeat it every 2 years unless the patient has symptom or the FIT becomes positive. If the FIT becomes positive, then we refer it to colonoscopy. If it is normal, then again, we keep on repeating the FIT every 2 years. So for this one, again, they will give you someone whose age is 55 or 60, and the patient is here for screening purposes. So what is the next step? Do FIT. Or they give you another scenario, the patient has done the FIT and it's normal. What is the next step? Repeat it in 2 years. Or in a different scenario, do you have somebody that who has been in your clinic and the FIT has been positive? So what is the next step? Colonoscopy. Okay. So high risk, first degree relative with a colorectal cancer or advanced adenoma, hereditary syndrome, inflammatory bowel disease, prior high risk polyps, need colonoscopy, need colon-based plan. Do not miss symptoms, rectal bleeding, iron deficiency. So sometimes they may give you a scenario which is very important. I would like you guys to pay attention. They may give you a scenario about someone that who has no symptom. Has no symptom. The only thing that you find is a lab result, which is not normal, and the patient has iron deficiency. That iron deficiency is an indication for someone that who is above 50 to do upper and lower endoscopy. So upper GI endoscopy and colonoscopy. Okay. So they might test you. They may give you a scenario about the elderly who probably has a symptom or do not have any symptom, but the patient has bleeding. The patient has iron deficiency. When you check, you can find the fecal occult blood test is positive or FIT is positive. So the next step would be to do upper GI endoscopy and colonoscopy. So unintentional weight loss. Change in bowel habit, abdominal mass, these requires diagnostic colonoscopy, not FIT. So again, if the patient has symptoms, forget about FIT. Forget about screening. Go after diagnostic tools. Lung and prostate cancer. For the lung cancer, so who is eligible? What tests do we do? What are the interval? And always we should add what. So eligible, age 55 to 74 plus, anyone that who is smoking 30 packs or more than 30 packs, or who has quit smoking but less than 15 years. So they are eligible to go under lung cancer screening. So test, what do we do? Low dose CT scan, not chest X-ray. So if they give you a scenario about someone that who has been smoking for 40 years and his age is like 55, 60, 70, so don't go for the, and even if they ask you initial screening, the initial screening is the low dose CT scan, not the chest X-ray. Interval annually up to 3 years. So once you do the CT scan, even if it is clear, the patient has no abnormality found in the lung, it means that I have to do it 3 times every year for 3 consecutive years. Always add smoking cessation support. So it means that we have to let the patient know that we have all the support and services to help him quit smoking. So that is priority number one. Prostate cancer, average risk is do not order the PSA automatically for everyone. Like, for example, you're 55, so you have to do the PSA. Unless the patient is taking some sort of medication, or if you're suspecting that the patient may have this issue, then you can. Otherwise, automatically for everybody based on their age or their gender, obviously, you don't do that. Approach, shared decision making about the benefits, false positive, overdiagnosed biopsy harms. High risk, discussed earlier if a strong family history or high risk ancestry. Symptom, diagnostic evaluation, not screening. Obviously, if the patient has symptoms, we are talking about diagnosing, not screening. Symptoms override screening rules, which we did mention it a few times, which is a common mistake made by IMGs. That's why I'm trying to insist more on that so that you don't make the same mistake. So clinical clue, rectal bleeding, iron deficiency, weight loss, diagnostic colonoscopy, or urgent GI pathways, do not order FET. Why? Because the patient has symptoms. Breast mass, nipple discharge, skin tethering. So if you see any of them, do not go after routine screening. Go after diagnostic mammography plus minus ultrasound. Post-coital bleeding or visible cervical lesion, pelvic exam, cervical testing, colposcopy pathways, do not do routine. Again, if there is symptoms, go after diagnostic. Hemoptysis symptom, weight loss, persistent cough, so diagnostic chest imaging and cancer pathways. Like if the patient is smoking for 40 years and the patient has no symptoms, you do the low dose CT scan. But if the patient is smoking for 40 years or 60 years, but the patient has cough, you don't do that. You go after the initial diagnostic tool, which is the chest X-ray, not the CT scan. Once the patient is healthy enough to go under radiation, then you can go ahead and do the CT scan later after the patient feels better. But at the moment, since the patient has symptoms, you forget about the screening. You just do the diagnostic, which is the initial chest X-ray. Initial imaging is the chest X-ray. But once the patient feels better, then if you want to do the screening, then you move on and do the low dose CT scan. Pulsatile abdominal mass with pain, urgent abdominal aortic evaluation, not screening ultrasound. So for someone that who is over 60, and the patient is smoker, you can do at least once abdominal ultrasound as a screening. So remember, when it comes to abdominal aortic aneurysm, pay attention to the wording of the last sentence of the scenario. Like the scenario might be 4 or 5 sentences, but the last sentence is the most important part of the whole scenario. So let's say they give you a clear-cut picture of someone with the abdominal aortic aneurysm, but what is the last sentence asking you specifically? Is it asking you what is the best investigation or diagnostic investigation, or it is asking you what is the best screening option? So if it is asking you what is the best screening option, it is CT scan. If it is asking you what is the best sorry, if they're asking about the best screening option, it's abdominal ultrasound. If they're asking you about the best diagnostic option, it will be CT scan. Okay? Or if they may give you somebody with the abdominal aortic aneurysm rupture, none of the above. The next best option will be urgent laparotomy. Take him to the operating room and open. Okay? Suicidal ideation, immediate risk assessment, and safety planning, not routine screening questionnaire. Cardiovascular and metabolic prevention. All right. So blood pressure and cardiovascular risk. Blood pressure measures periodically in adults. Use correct cuff and resting technique, which these are like basic stuff. I'm just skipping them. Repeat if elevated, confirms with the office repeats, home blood pressure or ambulatory blood pressure when appropriate. Risk assessment. We check the age, the sex, the blood pressure, the lipid level, diabetes, if the patient has any comorbid condition like diabetes, chronic kidney disease, if the patient is also smoking, family history, and established atherosclerosing, sorry, or cardiovascular disease. Exam traps, severe blood pressure with the symptoms or organ damage is emergency assessment. Lifestyle is universal for all of them. Medication decision depends on the confirmed blood pressure and global risk. These are the basic. We are going to go ahead and dive deep into it a little bit later in the upcoming slides. So lipids and diabetes screening. So lipids, cardiovascular risk. Who? The exam answer would be adult over 40 or earlier with a risk factor. So lipid and diabetes, remember that for anyone, anyone with diabetes mellitus type 2 above age of 40 or above age of 40, he's automatically candidate for statin, regardless of the lipid level. Let's say they gave you a scenario about someone who is 45 years old. He has diabetes mellitus for, let's say, 10 years, and the lipid profile is normal. And he's taking everything for the diabetes control. What is the next best step? One of the options is to start statin. So remember, anyone, despite the level of, or regardless of the level of the lipid, statin is indicated in anyone age of 40 or above with diabetes mellitus. The existence of diabetes mellitus plus age of 40 and above is an indication to statin usage. Okay, so you don't have to have a high lipid to start statin for anyone with diabetes if the age is above 40. Repeat about every 5 years, age 40 to 75. This is for the repeating the lipid. Tool, global CV risk modify Framingham, CLEM, depending on the test. Treat based on risk categories, diabetes, chronic kidney disease, and the cardiovascular LDL, CNAN, and HDL-C ApoB. So diabetes, adult age 40 or above 40. Interval at least every 3 years. Early or more often if the patient is obese, the patient has gestational diabetes mellitus, polycystic ovarian syndrome, HTN or hypertension, dyslipidemia, family history, high risk, ethnicity, or prediabetes. Again, this is red. Please remember it. Commonly part of their questions. Test hemoglobin A1C, fasting glucose, or OGT, depending on the context. Adult immunization review, influenza is annually done, strongly emphasized for older adults, for pregnant, chronic disease, healthcare workers. So if they give you a scenario and any of these is part of that scenario, so if you have influenza in the options, go with that. Okay? They might give you somebody who is elderly, or they may give you someone who is pregnant, and they may give you somebody who has a chronic condition, let's say chronic kidney disease, or somebody that who is nurse, midwife, or healthcare professional working in the hospital or healthcare settings or environment. So what will be the best option in terms of vaccination? Influenza. COVID-19, which is very commonly tested nowadays, follow the current NACI or prevention seasonal guidance, especially older high-risk patient, is the same thing like influenza. TDAP and TD are tetanus diphtheria. Once in adulthood, if not previously received. So they may give a scenario about somebody that who has not received it before, and one of the options that you have is the TDAP, TD, based on the condition or based on that scenario. So the TD and TDAP booster every 10 years. They hardly ask you directly about this, but they may indirectly mention it in the scenario. For example, the patient had this, but it was like, let's say, 20 years ago. And so you know that the patient needs the booster now. Why? Because it was more than 10 years before. And for all pregnancy, you need this. Okay? Very commonly tested. Let me make it red. Pneumococcal. Pneumococcal adults 65 and above and younger, high risk. So usually for anyone who is 65 and above, it is annually recommended. But someone that who is younger than 65, let's say 45, but the patient is very high risk. The patient has some sort of, let's say, organ transplantation, like kidney transplantation, and the patient is currently taking immunosuppressant, or somebody has chronic condition and the patient is receiving a steroid for a long term or long time. So in that case, these are candidate. But usually based on age, it's supposed to be above 65. But if it is less than 65, they should be a candidate. They should be a high risk. And I mentioned the high risk conditions. Shingles. So very commonly mentioned that in the exam, the shingles recombinant zoster vaccine for older adults, and commonly ages 50 or above 50, depending on eligibility. So there was a case, I don't remember the subscription that to give you the name of the specific subscription, but I have seen a case that there was someone who was 45 years old and developed herpes zoster. So the patient developed shingle around 45, and then does the patient need a vaccination? If yes, when? So the patient needs, if you develop shingle, you need the vaccination after a year after a year of the onset of the shingle. Okay, so you get the treatment and then you need another vaccination after a year of the shingle appearance or onset. HPV routine adolescent vaccination, catch up based on age, risk, provincial criteria. MMR, varicella, hepatitis B. So check immunity risk, especially newcomer, healthcare workers, students, and pregnant, someone that who is planning to get pregnant. For pregnancy, remember to avoid all live vaccination, but you can go ahead and give the uh, influenza and also TDAP and hepatitis type B. Special immunization situation, pregnancy gave this one, very commonly tested, please remember it, that gave TDAP vaccination in every pregnancy, give influenza and seasonal if the woman is pregnant, but it is the time, let's say it's around October, November, and December, then you have to also uh, give him the influenza. Follow current COVID-19 guidelines, which they will provide you. Avoid live vaccination during pregnancy. This is red, and the reason I made it red again, it will be commonly tested. So you need to avoid all the live vaccination during pregnancy. Check rubella, varicella immunity before or after pregnancy. So anyone that who wants or who is planning to get pregnant, so we need to check all these uh, conditions or viruses. Immunocompromised. Avoid most live vaccines in severe immunocompromise. So it is not only contraindicated for pregnancy, it is also contraindicated for someone that who is severely immunocompromised or who has been taking the immunosuppressant. Inactivated vaccine may be less immunogenic. Vaccinate household contacts when appropriate. Use a specialist, public health guidance, or complex cases. Newcomer and healthcare worker. Review the documentation very clearly. Do not assume immunity for anyone that who is coming from a country with an endemic condition. Do not assume that he is immune. So you have to document it and you have to go ahead and do all the necessary steps. Catch up according to the Canadian schedule. Obviously, healthcare worker needs proof of immunity for key vaccine preventable disease. Counseling and behavior prevention. This is very, very important for someone that who is also preparing for NAC OSCE because not one of the station, probably you get between 2 to 4 stations that you may do the uh, history and counseling. It's a combo. So counseling is very important for somebody that who is doing NAC OSCE. Tobacco or alcohol counseling. So tobacco, ask advice and assist. So no smoking status, always for any condition that you're taking history, always we have a specific area, which is the social history. So in the social history, we always ask about alcohol, we always ask about smoking, we always ask about recreational drugs, and also we are asking about sexual life of the patient. Encourage every smoker to quit regardless of the duration and regardless of the numbers of the cigarette per day. We always offer. We always offer. Have you ever thought about quitting smoking? Just offer. If the patient says, you know what, yes, I want to, but let's leave it for the next visit. Or the patient says, you know what, I have tried it so many times and I failed. Do you think it's going to work again? If I try it again, then you will say, you know what? Yes, the reason you fail, it is not only you, anyone that who tries to do it without healthcare support or healthcare assistance, they usually fail because they don't know the proper way. And we are here to help you and walk you through all those steps. And then you move on. And if it is something that you have to do and that counseling, then you take on that. Otherwise, you just, you know what? We have all the services. We have everything that you need to help you quit it in a very healthy way, and you will be successful. And we make sure that it is a successful process. But let's do it in a separate visit. and then you continue doing whatever the counseling station is. So you're not deviating from that station, but you just mention it. So regardless of the number of the cigarette, regardless of the duration, regardless of the how long he has been smoking, offer. Okay. Offer behavioral support, quit lines, nicotine replacement therapy, varenicline, which is the best choice. They might ask you, this might be in the exam, that if the patient is not responding to the STAR or not responding to nicotine replacement therapy, what is the best medication? Varenicline. Sometimes you also go for the second best option, which is bupropion, or you can combine it. In worst case scenario that nothing helps, then you can combine both. And when you are using this, please pay attention to the history of the patient. If the patient has any sort of eating disorder, it is a contraindicated. This medication is contraindicated. If the patient has history of seizure, it is contraindicated. Okay. Use shared decision making and revisit readiness. Alcohol lower risk means lower intake. So there is no amount, no alcohol in pregnancy. There's no amount saved during pregnancy. This is something that you need to know and always consult when you're doing the consultation for your patient, especially if your patient is planning to conceive. You need to make sure and raise it that there is no safe amount during pregnancy. Okay. So ask quantity, frequency, binge pattern, and consequences. Console lower intake to reduce risk. Screen for the alcohol use disorder when functions, safety, liver disease, pancreatitis, depression, or injury suggest harm. So we have done the alcohol. I don't know if you guys have done the smoking. I think we did it in Nakoski, but we have already done the alcohol. What are the options? Which one is used when? And we might discuss and cover it today as well. A patient is not ready to quit should still receive brief advice, empathy, harm reduction, and offer of support. Do not dismiss or shame. Okay. We never judge. And also remember that when you're doing the counseling, we are going to approach in a very non-judgmental way. So if somebody says, you know what, I'm not drinking a lot, or I'm just drinking occasionally, the occasionally is not a good uh, answer. So you need to ask a follow-up question. What do you mean by occasion? Occasionally, because occasionally for me, it might be just once a month. For you, it might be once a week. For an alcoholic patient, it might be once every 2 hours. So occasionally is different from person to person. So always do a follow-up question. So the patient says, I'm drinking occasionally. So what do you mean by occasionally? And also if the patient says, you know what, I'm not drinking too much, I'm just drinking 10 beers a day. Wow. So wow, or changing your facial expression shows that you're judging the patient. So be careful. I don't know if you guys have attended the NACOSKI. We always ask our candidate to, when they're doing the station, to turn on the camera because facial expression and the way you are um, reacting to some of the action the patient may have, it really makes a lot of difference and it may cost you a lot of mark. So it should be any counseling, any bad habit should be approached in a very non-judgmental way. So if the patient is drinking 10 beers a day, okay, so non-judgmental. So we're not here to judge anyone that if he is drinking that's too much, or if he thinks that's not too much, but for us it is actually too much. But we are not here to judge. We are here to provide support. We are here to provide empathy. We are here to provide them the best service that he deserves as a Canadian. Okay? Physical activity, nutrition, and weight. Physical activity, aim for 150 minutes per week. That's something that for everybody we uh, encourage everybody to do that. And also moderate to vigorous aerobic activity, add muscle training at least 2 days a week. So it means if you're asking them to do 3 days cardio, at least 2 days muscle strengthening. Older adults needs balance training and fall prevention for somebody that who's very frail, who's very prone to falling disease. We always ask them to have a trainer so that they can look after them while they are exercising. Because sending an elderly, frail patient who is prone to falling disease to the gym to exercise on his own is not a good decision, not a healthy decision. Uh, um, and usually it fails and it backfire to the patient and to your practice. So always, if you're so your job is not done if you are giving them a consultation, but 50%. The consultation has to cover the whole thing, so it has to be 100%. If I'm counseling you or encouraging you to do exercise, this is my responsibility to make sure that you do it in a proper way, in a healthy way, in a safe way. So if I just ask you to do the exercise, you're not going to get any good points. We probably get 2 out of 5, which is not good. But if you say that you need to see a fitness specialist or a trainer who can walk you through all these exercises and make sure that you don't fall, then you get 5 out of 5. Okay. So your job is not done unless you make sure that the patient is doing everything in a very safe way. Nutrition, Mediterranean or dash style pattern, more vegetable, fruits, whole grain, nuts, fish, unsaturated fat, reduced sugary drink, exercise, sodium, and uh, ultra processed foods. So these are the things, but depending on the situation, depending on the condition, we are going to mention some of them, but we are not going to deep dive into the nutrition because this is not part of our job. Remember, when you're doing the exam for the MCQ1 and NACOSKI, especially MCQ1, you are approaching the station, approaching every case as a GP, not as a specialist. So we can just provide them with a big stuff like dash, do this and that, and that's it. But if you want to dive deep into nutrition, that's not your part of your job, and you're not going to get any question out of nutrition that how much is the percentage of the fat for this patient and the carbohydrate for this one for this patient, or for example the salt and this and that. No, those are part of the specialist job. So as long as you know the big stuff, like at least if you are suffering from hypertension, you need to uh, cover the dash, you're good. Okay. Weight counseling focus on health, function, cardioembolic risk, sleep medication, and sustainable behavior. Avoid stigma, screening for eating disorder risk, and vulnerable patient. So when it comes to female amenorrhea, remember always rule out or exclude the anorexia nervosa. They love to test you on anorexia nervosa. They love to test you. Why? Because we have a lot of case of anorexia nervosa in Canada. So this is gonna be in the exam. So they might not mention it directly. They might give you the case indirectly. For example, you have a patient, your patient is, let's say, 20 years old, and the patient is brought to you by her parents because the patient has missed or the patient doesn't have regular mens, or the patient is, um, for example, yeah, the patient is not having mens for 6 months or for 3 years, 3 months or 4 months. In that case, they're indirectly uh, mentioning or indirectly pointing toward anorexia nervosa that you need to cover this. So you have to ask about, if you're doing the NACOSKI, you have to ask about the weight, you have to ask about the BMI, you have to ask about exercise and about how many times per day he's exercising and how intense and what does he think about his weight. And if it is MCQ1, probably they will ask you what is the best next step to do. So if they give you a BMI and the BMI is less than 16, then obviously you have to admit the patient, right? So anorexia nervosa, when it comes to counseling for nutrition or amenorrhea, please remember that. Mental health and safety prevention topic, MCQ, and focus points. For depression, do not routinely use the questionnaire screening. For all asymptomatic adults, assess clinically when symptoms exist. For the suicide, I don't know if you guys um, uh, know the mnemonic for the depression. For the depression, we have a mnemonic which is MIECG pass. So MIECG pass. This is a mnemonic that I made for depression to make it very easy if you want to take a history, or if someone that who is depressed, an MCQ one, they might mention at least 5 of these MIECG pass. So for the depression, you need these two, which is mood, low, and eyes interest loss. If you have mood low or interest lost, you have a depression, most likely. But based on the criteria, you need to have one of these and at least 4 or 5 of the rest. For example, interest loss, energy loss, concentration loss, guilty feeling, psychomotor retardation or agitation, appetite increase or decrease, suicidal ideation, sleep disturbance, and sexual dysfunction. So if somebody has M plus 4 or more than 4 more symptoms, the patient has depression. So if the patient has mood is low and then interest is lost, obviously if interest is lost, you don't have to worry. M plus I is equal to depression. But let's say if you don't have interest lost, mood is low, energy is lost, concentration is lost, guilty feeling, psychomotor retardation or agitation, then you have your depression. Or maybe you have appetite loss, you have sleep disturbance, you have sexual disturbance, or you have suicidal ideation. Again, you have depression. So this is how it works for depression. If you haven't done it or if you don't know it, we will repeat it once the lecture is done. You can ask me, I will write it again. So suicide, any suicidal ideation require immediate safety assessment and management. For suicide, remember the sad person. There is a mnemonic for sad person. We can discuss that one as well. Substance abuse, ask clinically when risk, symptoms, injury, liver disease, mental health, or social impairment. So depression, you will 100% get question out of depression. There's no question about it. There is no maybe. There is always there. Depression is always there. There's no maybe question from depression. It is always there. If you're doing Nakoski, there is 100% one station of depression. So this is not something that you can just take it lightly. You have to know it by heart and you have to know everything about depression. And if you are a member of Jala Academy, you should have a lot of cases. I think we have around 100 to 200 cases about depression that has ever been in the exam or in any subscription. We covered them all. So do all those cases and read the topics and you should be fine. For the suicide, I'm pretty sure that you have the notes, but I have very nice short note about suicide. Yesterday I could not locate it, but I will definitely find it and upload it in your account. Substance use disorder, 100% it's going to be in the question. There is no maybe. This is going to be 100% in your exam. Read about the substance use disorder. Make yourself familiar with the sign and symptom of the toxicity. Make yourself familiar with how to treat the acute substance use disorder condition and what are the antidote. So these are the 4 important things that you need to know about substance abuse disorder. They are going to be in the exam. There's no question about it. Okay, please read it. You definitely have it in your account. If you don't, I'm pretty sure you have it. So if you don't, if you're not Jala Academy member, I'm pretty sure that you can find it in other resources. Please read it. Intimate partner violence. 100% it's going to be in the exam. Ask privately when clues exist, validate, assess immediately safety, and document and offer resources. So for intimate partner violence, again, it is as essential as depression because you will 100% get a case out of this one. So depending on the scenario, depending on the scenario, you should know what kind of support you can offer for the patient, or what is the question based on that scenario. That is it asking you about the safety plan, because safety plan, it has a proper plan how you can go for it, or what are the questions specifically asking you? Do you have to report it to the doctor, which usually we don't do it unless the patient is giving you a green light, and usually we encourage the patient to do it herself or himself. So it's not always the male, it could be the female who is the uh, abuser. So, yeah, it really depends on them if they want to take it to the uh, police, but it is not mandatory. Clinical clues for the intimate partner violence, frequent unexplained injuries. So these are the clues that they may include it in the scenario, and based on that, we know that the patient. So for the intimate partner violence, usually the case is very vague. The case is going to be very vague, but there are some clues that they are signaling toward the intimate partner violence. For example, the injury is there, but there's no good explanation for it, right? For example, the patient has a cat in his arm, and when you ask the patient says that I just fall down and I fall down on the floor. So it doesn't explain the clear cut that that's most likely by the knife, which the patient says that I just fall down and I have a clear cut on my shoulder. So usually the explanation doesn't match with the mechanism of the injury. An anxious partner control visit. For example, you have a patient who is in your office and you have hard time taking history, and somebody who is accompanying your patient is very anxious. He's going back and forth, he's pacing, and he's mad, and he's always saying, like, you know what, we are late. Wrap it up. We are late. Wrap it up. It's not something serious. Just give him some medication and let us go. So these are the things that should give you a signal that this might be an intimate partner violence. Depression, anxiety, usually they come with the very vague symptoms. For example, always they come with a headache, but this headache doesn't match any condition. It doesn't match the migraine. It doesn't match the cluster headache. It doesn't match the stroke. It doesn't match the subarachnoid hemorrhage, the tension headache, the glaucoma. It doesn't match any of the headache that we know. Or the patient always comes with a vague abdominal pain. So usually remember, the most common complaint that the patient comes is headache, if they're being abused, headache, abdominal pain, fatigue, and sleep insomnia. These are the four commonly symptoms that someone with abuse will visit you. So if you are suspecting, then ask directly, how are things at home? How's your husband? Is he supportive? Are you being pushed? Are you being called? So you have to ask all those direct questions. But before you do that, always provide confidentiality, because if you don't do that, they cannot open up. For example, everything you say will be kept confidential between me and you, and I will not disclose it to anyone unless it is asked by the law or yourself. So once you provide them with the confidentiality, then the patient will open up and give you all the information that you need, because he feels safe or she feels safe. Otherwise, if you just directly ask, how are things at home? He's not going to answer you. unless he or she knows that you are keeping everything strictly confidential. Okay. Inconsistent history, again, delayed presentation. For example, the injury happened, like, let's say, 6 days ago, and now the injury has been infected. Now the patient is in your office. He's seeking medical attention now after 6 days of injury. So that should raise eyebrow. Exam traps: do not confront the partner or force the patient to leave. So if the partner or somebody who is accompanying your patient, who is the abuser, this is not our job to confront him or fight with him that what you're doing is wrong, or you have to do this or that. No, we're just asking the patient that we need to do some X-ray and we need you to the next room. And for that, you need to be alone with the patient. If they're gonna confront you, then you just let them go. Okay? Unless you know that the patient is in danger. If the patient is in danger, then that's your responsibility to involve the authorities. Prioritize privacy, autonomy, safety planning, and resources. Sexual health and STI prevention. Who needs sexual transmitting infection screening? New or multiple partners. If someone has a new partner and he's not practicing safe sex, he's not using condom, or if he is or she is using condom, it is inconsistent. Or the patient says that I have multiple partners, I sleep around, I'm enjoying my life, and I don't have one sex partner, I have multiple. So in that case, we have to do the screening. Prior sexual transmitting infection is another indication for the screening, or if men who are having sex with other men who's engaged in sex with other men. So sex worker or transactional sex, inconsistent condom, pregnancy, and sexual assault care. Somebody that who has been raped. Uh, what to test? So the thing that they love to test you is NAT for chlamydia and gonorrhea. The best test is NAT. Okay, this is going to be in the exam. HIV, antigen antibodies, syphilis serology, hepatitis B, C, F risk, pregnancy test when relevant. So HIV prevention, we have PrEP or pre-exposure or post-exposure. If somebody that who is engaging in risky behavior, but he is not affected, for that we use the PrEP or PrEP or pre-exposure as a prevention. Then PEP or post exposure is for somebody that who has been affected or exposed. Then we use that. So basically, you have to pay attention to the scenario. What is going on in the scenario? Let's say they give you a scenario about somebody that who is having, for example, let's mention this: somebody that who is sleeping around a lot and using the condom inconsistently, and he is a bisexual person. So for this person, when you test, everything is normal, or he doesn't have any for example, he hasn't been involved with anyone that who has had HIV. For that person, so you do the PrEP because it's ongoing, but the patient is not exposed to any HIV patient. Or let's say somebody that who is a nurse and he get poked with a contaminated needle of HIV. For that, then the patient has been exposed or affected. Then you do the PEP. Bone health, pregnancy, and older adults. Bone health, calcium and vitamin D, weight-bearing exercise, fall prevention, osteoporosis screening, for pregnancy, prenatal counseling, folic acid, routine antenatal screening, vaccination review, older adult, fall prevention, medication review, vaccination, and function. So we're going to discuss all of them in details. Osteoporosis and falls prevention. Bone health. So female 65 and above. Risk assessment first. B, bone mass density if affects the management. Sorry. Risk factor, fragility, fracture, glucocorticoid or steroid, rheumatoid arthritis, smoking, alcohol, low weight, family hips, fracture malabsorption. So these are the risk factor that they may mention in the scenario. Not may, they will definitely mention it in the scenario. So keep that in mind. Fragility fracture, evaluate and treat as a high fracture risk, not just CASM advice. Bone mass density use when it changes risk classification or management. So falls prevention checklist, falls in the past year, gait balance, orthostatic symptom, vision hearing, sedative. So for any falling condition, or if you're suspecting that the patient may have falling, for that we need to have a proper information or a complete information about the patient history, about the previous falls, about how the patient balances, if the patient is taking any sort of medication that may affect the autonomic system, or if the patient has any vision problem or hearing problem, or the most important thing, which is the common cause for the falling disease, is polypharmacy. Polypharmacy and usually some specific medication in that polypharmacy. One is the number of the medication. Let's say if someone is taking 10 or 12 medication at the same time for different conditions, that number of the medication can cause the falling or increase the risk of falling. So we need to find a way to cut down on those numbers. For example, the patient is taking 12 medication and two of them is, let's say, Tylenol, and one of them is Tylenol, one of them is, like, let's say, antihistamine, and one of them is, let's say, aspirin, and one of them is Tylenol. So if we have to cut down, we're going to cut down on the ones that are causing more risk of fall, and we keep the one that's more safer. For example, out of all of this, I will keep the Tylenol, I will decrease the non-steroidal anti-inflammatory drug, I will cut down on antihistamine if it is possible, and also the aspirin if the patient is not having any sort of, let's say, cardiovascular disease or inflammatory disease. So you keep the one that's the safest and cut down on the ones that they are kind of extra medication. Because sometimes you prescribe, let's say, 8 medication for your patient, and then the patient is adding on top of your prescription a few more. Then when you review the medication, which is the most important part of the falling disease, you see a lot of the medication, see which one is extra, cut down on them, not on those ones that they are dealing with a very serious and vital condition. The one that they are extra, cut down on the numbers. It will help and decrease the risk of falling. And then the this is the number. Now the content of the medication. Which medication is more sedative? Because that is increasing the risk of falling. That's supposed to be done by the specialist, not you. But those are the ones that we have to ask. If it is not mentioned, we have to ask. We have to make sure that we know if the patient is taking. Because if that is the problem causing the risk, we have to refer it to the specialist to find an alternative which does the same function but decrease the risk of falling. Okay? Like sedative, any kind of sedative, benzodiazepine, opioid, and anticholinergic medication. Alcohol, footwear and home hazards, strength and balance exercise. Pregnancy and preconception prevention. For the preconception, folic acid We recommend it for everyone to start it at least 3 months before conceiving. And usually it really depends on what the patient is taking, what sort of medication the patient is taking, what is the past medical history of the patient, the dosage will be different. Start before conception, dose dependent on a baseline and high risk factor, which I mentioned before. Medication review, before the patient start conceiving, we have to not only start the folic acid, we have to take a full history to make sure that the patient is healthy enough to get a healthy pregnancy, to have a healthy pregnancy. So we have to review the medication. So if the patient is taking some sort of teratogenic medication, like let's say if the patient has hypertension, the patient is taking a ACA inhibitor or ARBS, isotretinoin, or valproic acid, warfarin, methotrexate, we have to find an alternative for them. So these are the medication that they are teratogenic, and there has to be an alternative, which there is, and we have to change it. Immunization, we have to check before conceiving. We have to check the rubella, varicella, hepatitis B, avoid live vaccination during pregnancy, and also this one has to be done every pregnancy. Substance, no amount of alcohol is safe during pregnancy. If the patient is smoking, stop smoking. At least we offer counsel against recreational drugs. Chronic disease, optimized diabetes, hypertension, thyroid disease, epilepsy, mental health before conception. So these are the things that we have to, obviously, when you take the history, you know that in history, we're covering the post-medical history, the current medical history, we are covering the medication, we are covering the family history, we are covering the social history. Based on that, we counsel the patient to make sure that the patient is healthy and the patient will have a healthy pregnancy. Pregnancy screening, gestational diabetes, this is very commonly tested. Please remember that they might mention this indirectly. For example, they give you a scenario about someone that who is 26 weeks gestation and they are asking you about screening test. So what kind of screening test do you do? Obviously, you check for the gestational diabetes mellitus. Why? Because 26 is right at the middle of 24 to 28 weeks of gestation. And for the GBS, they might give you, which is 35 to 37. They may ask you, they may give you a scenario about someone that who is, let's say, 36 weeks of gestation and which kind of screening test is supposed to be done. And then you go ahead and do the GBS and also the ROGAM when indicated. All right. Sorry. Older adult prevention. Assess function first. The activity of daily living, mobility and falls, frailty, driving and safety, vision, hearing, social support and caregiving strain, medication polypharmacy. I think we did cover all of them, so I'm going to skip this. Hypoglycemia, when to stop, limited life expectancy, which I mentioned. For example, the patient is going to die in 2 months, then they're wasting of the resources, right? So severe frailty and advanced dementia, uh, all this we did mention it. So do not screen routinely. Like this one, we don't do it routinely. First of all, if they want to ask you about ovarian cancer, usually, which commonly tested, and I have seen it in every single subscription, that they are asking, or there is, for example, a woman that who is asking for a ovarian cancer screening. So we don't have any routine screening for ovarian cancer. Okay, so this will be in the licensing exam because very commonly asked question. Chest X-ray for the lung. So the low dose CT scan is used only for the eligible high risk patient. For low risk, we don't do the chest X-ray. We don't actually use the chest X-ray as a screening. We use it as a diagnostic. ECG in asymptomatic low-risk adults, usually not routinely done. Carotid ultrasound, asymptomatic, we don't do it. Whole body CT or MRI, we never do it. Tumor markers, not the screening test for asymptomatic average. So just to make it very simple, no symptom, no uh, diagnostic test. PSA automatically for all, we don't do it. Uh, repeat fit after positive fit needs colonoscopy. Okay, we don't repeat the fit after positive fit. Best next step algorithm, is the patient symptomatic? If it is yes, diagnostic workup. Is the patient in the eligible age group? If no, avoid screening unless risk factor is present. Does risk change the pathway, family history, smoking, immunocompromised, pregnancy, and frailty? What is the recommended test for screening? FIT, HPV, PAP, mammography, low-dose CT scan, ultrasound, blood pressure, hemoglobin A1C, and lipid. Will screening change management? Consider life expectancy, goal of care, and patient value. So now we're going to do a few cases. Based on these lectures, we're going to do a few cases. So a 56-year-old average risk patient asked about colorectal cancer screening. So we have 56-year-old average risk patient, and he is asking you, who is writing on my screen? Please stop writing. Okay, so a 56-year-old average risk patient asked about colorectal screening. So no bleeding, no anemia, no weight loss, or no family history. The best thing is, because the patient has no symptom, what should I do? I do a screening test, not diagnostic. I do a screening test because patient is above 55. So for above 55, I do FIT. And if it is normal, I repeat it every 2 years. If it is abnormal, FIT comes back positive, my next step will be colonoscopy, which in this case it is. A 59-year-old has iron deficiency anemia and fatigue. That's the only symptom he has, but still it is a symptom, right? The patient has symptom, no prior colorectal cancer screening. So now I don't do the screening. Why? Because my patient has symptom. See, here I said no symptom. Here has symptom. So diagnostic colonoscopy, not screening. Now, case number 3, a 61-year-old patient with 35-year pack of cigarette quit 8 years ago. So he's using 35 packs for 35 years, sorry. And the patient quit it just 8 years back. Still, it is less than 15 years. So for this patient, the patient is not having any symptom. For somebody who doesn't have any symptom, we still can do screening test. So my patient is about 55. My patient has no symptom. My patient is smoking for 35 years or more than 35 packs per year. And also he quit less than 15 years. Still, he's a good candidate for low dose CT scan. If I do my CT scan and the CT scan comes back normal, what is the next step? I repeat it 2 more times. It means I do it 3 consecutive years. For 3 consecutive years, if the CT scan is normal, then I stop. Otherwise, I keep on doing it for 3 years. Okay? If it is positive, obviously, based on that, I will decide. But if it is negative, I just repeat it. Case number 4, 26-year-old with a cervix. So it means the patient has not taken it out. 26 years old female. The patient has the cervix in place, sexually active, but asymptomatic. My patient has no symptom. HPV vaccinated. So HPV vaccinated does not exclude the patient or does not remove the screening needs. It doesn't mean the patient is safe if the HPV vaccination is done. I can still do the screening. It doesn't necessarily mean that the patient will never develop cervical cancer or the patient will develop cervical cancer. So, having the vaccination does not remove the need for screening. So, 26-year-old with a cervix, sexually active, so more than 25. So, age is important, more than 25, and the patient is sexually active, and the patient is asymptomatic. So, for asymptomatic, I have to do screening. HPV vaccinated, can I skip the screening because he has HPV? No. Still do this cervical screening according to provincial uh, program. Okay. Fine. 66-year-old man with no abdominal symptom ask about screening for abdominal aortic aneurysm. So one-time abdominal ultrasound. Anyone above 60 and 65?
65.
65. Anyone above 65 with the screening, if he is asking about the screening, we do at least one time abdominal ultrasound. If someone that who is less than 65, but he's a smoker, you still can do the abdominal ultrasound because the smoking is a very strong risk factor. Okay. So an 86-year-old with advanced dementia is offered colon cancer screening. 86, life expectancy is very low, and the patient has advanced dementia. Avoid low benefit screening, focus on comfort, goals, and function. One page high yield recap. So we are going to recap the whole lecture. So colorectal cancer, average risk, ages 52, 74. We do what? FET every 2 years. If it is positive, then we do colonoscopy. For the cervix, screen if cervix present and eligible. HPV-based program increasingly starts at age of 25. So anyone 25 and above is a candidate for HPV testing. If it is normal, we repeat it every 5 years. And breast mammography, usually we started at age of 50 and above, but depending on the condition, depending on the risk, depending on the patient decision and family history, we can start it at age of 40, and we repeat it every 2 years. Lung, age 55 to 74, plus 30 packs per year, plus more than 10 years, and also plus current or quit less than 15 years. We do low dose CT scan, not X-ray. We do X-ray or chest X-ray if my patient has symptom. Once I deal with those symptoms and the symptoms are resolved, then if I have to do the screening and the patient meets this criteria, I will do the CT scan after. Abdominal aortic aneurysm means 65 and 80, one time abdominal ultrasound at least. Again, if they give you a scenario about someone that who is 65 and between 65 and 80, and they're asking you what is the best screening test, it will be ultrasound. If they're asking you the best diagnostic imaging, that will be CT scan. Diabetes, age 40 and above, screen at least every 3 years, early more often if risk factor is positive. And remember, for the diabetes, if anyone with diabetes mellitus age 40 is a candidate for statin use regardless of the result of the lipid profile. Even if the lipid profile is normal, you start statin. Lipids, adults again here. 40 and above 40, lipid cardiovascular risk assessment, repeat about every 5 years. So this is different. Depression, no universal questionnaire, and tobacco encouraged for cessation. And guidelines. So these are the guidelines. And thank you very much.